I think testing right now is in flux in terms of first even starting to do it, and then who are we going to choose to do certain molecular testing on. I think the standard, certainly consensus language would be that we test our patients with what we call non-squamous lung cancers, specifically non-squamous, non-small cell lung cancers. It's that group of lung cancer that we know we're more likely to find things like EGFR mutations and rearrangements in EML4 ALK. I think, though, we're moving in a direction that we really want to test all patients, and I think it's even going to one day get beyond just lung cancer. It's do you have cancer? Shouldn't we test you for all the known alterations, and perhaps looking for things that we once thought were only unique to lung cancer or breast cancer or colon cancer, but now we're discovering can rarely be found in some of the other tumors that were unexpected. I think ideally, in terms of lung cancer, you would test everybody. You would test patients with squamous cancer, patients with small cell lung cancer, patients with non-squamous, non-small cell lung cancer. Right now, our program is an example of what's happening, I think, at a lot of places where we have kind of a reflex system in place where if a biopsy is performed, by a surgeon or by a radiologist, now we don't really have to ask for it. If a patient has a non-squamous, non-small cell lung cancer, our pathology department automatically, reflexively tests those tumors for EGFR and ALK. Now, I think that sometimes may not be appropriate for some patients who never have probably an opportunity to even go on to oral therapies. Maybe they're too sick, or maybe they choose not to pursue a therapy. And then you're just doing a test that costs money and maybe isn't going to help anyone. But I think for most patients, what it does is it saves some time. So by the time a patient comes into the clinic after being in the hospital, we already have biopsy results and can make some decisions in care.